Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I want to welcome you to another live stream where I answer your questions live. You can talk to me directly here by either clicking on the StreamYard link that I am posting into the chat pad now. You can connect with me here directly. Just click on the link and then you can talk to me directly, or you can post your questions in the chat pad and I will address them then. Before we go into today's questions, what makes me qualified to host an emergency questions and answer session for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager in critical care for over 5 years, and I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com, and I can very, very confidently say we have saved many lives with our consulting and advocacy. And you can verify that on our intensivecarehotline.com testimonial section, and you can verify it on our intensivecarehotline.com podcast, where we have done client interviews. Now, also, I want to welcome any viewers that watch this on replay. We have, a lot of viewers watching this on replay, and keep the questions coming so that I can create the content that you want. Also, if you like my content, subscribe to my YouTube channel, click the like button, click the notification bell, and share the video with your friends and families. And of course, comment below what you want to see, what questions and insights you have. So once again, that I can create the content that you want to see. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, you can get more information at intensivecareathome.com. We are providing a genuine alternative to a long-term stay in intensive care for long-term intensive care patients, adults and children, predominantly on ventilation with tracheostomy, but also on BiPAP, CPAP ventilation without a tracheostomy. We're also providing tracheostomy care at home without ventilation. We're providing home TPN, home IV potassium, home IV magnesium infusions, home IV antibiotics, home IV infusions, PEG, pitch, nasogastric tube, nasotracheostomy tube management at home, central line, PICC line, Hickman's and port management at home, as well as palliative care at home. And you can find more information at intensivecareathome.com. With Intensive Care at Home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. So let's get started with the first question that has come in during the week. I'm grateful for all the questions that are coming in, because that is when I can create the best content here. That's when I can create the best content here. So, the first question is coming from Patricia, and she says, "Hi Patrick, the hospital refuses to send my father to Virginia by telling the social worker my dad is not stable enough to be transferred. However, for the past 3 months, they've been trying to send him to a step-down ICU, and I have been refusing, and I was trying to get him home, but they blocked that because he's on a ventilator with a tracheostomy. But now I'm pushing to get him back home to Virginia so that he can get better treatment as well, so I can feel comfortable while visiting my dad, because I'm so stressed because they were calling me and harassing me because they were trying to get guardianship over my father. I wanted to know if you can help me to get my dad home to Virginia or transferred home, where he can be at home on a ventilator with a tracheostomy. Great question. Great question. So, well, first off, it concerns me that the social worker is talking about whether your dad is stable enough to be transferred or not. The social worker does not come with a clinical background, generally speaking, right? So for the social worker to make comments there is not appropriate. But more importantly, I do believe you need to get a second opinion here very, very fast. Because I can assure you, if your dad's been on a ventilator with a tracheostomy for 3 months, and they were trying to get him to a step-down ICU, I can guarantee you that he's stable enough to be transferred to another hospital. Case in point, why am I saying that? So many patients are being flown around, on ECMO, on high levels of life support, on inotropes, on vasopressors, on ECMO machines, on balloon pumps. No reason why your dad can't be going back to his home state. Also, a few years ago, as part of the work that we are doing here with intensivecarehotline.com, we were actually sending a patient home to Beijing from Melbourne, right? So, and that was a ventilated patient with a breathing tube, not with a tracheostomy. So that is much more risky to do a transfer like that, as opposed to transferring and flying someone on a ventilator with a tracheostomy. Much more risky. And yet we were able to organize it with a specialist care flight. So for the social worker to say your dad is not stable enough, and yet they want to push him to a step-down ICU, is a whole lot of nonsense. And whilst I haven't seen the medical records, while I haven't got any more information than the email that you've sent there, Patricia, it is sheer and utter nonsense. And your dad is certainly stable enough to go back home to his home state, right? A ventilator and a tracheostomy is no obstacle to be transferred. It's also no obstacle to go home. So, if they've been trying to send him to a step-down ICU, of course he would be stable enough to fly home, right? Because what that means is basically, with going to a step-down ICU, that means he must be hemodynamically stable, right? His ventilation settings are probably stable, so there's not much mucking around, right? And if you feel like he would be getting better treatment closer to home, well, then you should absolutely be pushing for that next step, 100%. In terms of the hospital trying to get guardianship over your dad, well, you got to speak to your lawyer, to your family lawyer, to stop them from doing that, right? And the question is, why are they trying to do that? What's the agenda there? Is there a hidden agenda? There probably is, but I'm glad you've spotted it and you still have time to put things in place. So, to look at home care, your dad sounds very similar to most of our other clients that we have with intensive care at home. Taking him home, especially if he's ready to go to a step-down ICU, won't be a problem. We have so many case studies on our intensivecarehome.com website. You can see that we can take your dad home very easily. And keep in mind, we are cutting the cost of an intensive care bed by around 50%. An intensive care bed costs $5,000 to $6,000 per bed day. And whoever's paying for that would have an interest in cutting that cost by 50%, right? Because that's how much intensive care at home costs, So once again, no brainer. And whilst your dad is unfortunately staring at 4 walls in an ICU bed with probably very little natural daylight, he is so much better off to go home where he will have community access. And that's what I keep saying over and over again. All of our intensive care home clients do have community access. That's why we are in a unique position to, create an ICU bed in someone's home, and yet manage to improve and provide a much better quality of life compared to any ICU. It's not even comparable, right? Compare patients and families having community access with a critical care nurse as opposed to staring at the wall 24 hours a day in an ICU with no natural daylight, without family being around or family needing to commute, whilst other patients are waiting for an ICU bed, can't get in. Once again, what we do is provide a win-win situation. That is what we do with intensive care at home, provide a win-win situation. No-brainer. No-brainer. So, let's go to the next question. So, the next question is coming from David, who says, "Hi, Patrick. The biggest challenge for me at the moment is weaning my dad off the ventilator after a TAVR procedure. He has a neurological disease, and the doctors estimate 35% chance he will need a tracheostomy." Now, well, why do they say he has a 35% chance he needs a tracheostomy? Where's that number coming from? That's very interesting. That's a very interesting number. Where's this coming from? Right? So, first off, let's look at the why is your dad not coming off the ventilator? That is the first question that I have to ask. Why is your dad not coming off the ventilator? Have there been complications after the TAVR procedure? TAVR is a transcatheter aortic valve replacement. So it's actually a minimally invasive procedure, which generally speaking should increase the chances of someone getting off the ventilator much faster than, if it's not a minimally invasive procedure, right? So they would have done the procedure under a video camera, under video guidance, rather than on an open chest. So the approach is much better. The approach makes a lot more sense compared to doing an open heart surgery, because that's what it is, generally speaking. So I assume that if your dad has a neurological disease, maybe he's struggling to come off the ventilator because of the neurological disease. You haven't shared what the neurological disease is. Is it that he's got some neuromuscular disease, right? Like, I don't know, motor neuron disease, cerebral palsy. Does he have, a stroke? What is it that he has, that he's dealing with, that stops him from getting off that ventilator for now? So that is one question that I have to ask. The other question that I want to ask is, have there been any complications after surgery? So common complications after heart surgery, after aortic valve replacements, are bleeding. Right? I've seen patients after aortic valve replacements bleed. Now, mainly they were open heart surgeries, not minimally invasive. But if bleeding has occurred, that can be a big challenge and is very concerning, right? So find out what has occurred there. Now, other challenges that can happen after transaortic valve replacement besides bleeding is irregular heart rhythm, such as atrial fibrillation, maybe even was in VF or VT, maybe they had to shock him, maybe they had to do CPR, maybe there was a setback there, other complications that can happen, depending on if there has been bleeding, electrolyte imbalances that could have led to further complications. Other complications that might have happened is a tamponade, which is internal bleeding. Did they need to open his chest, even though it was minimally invasive, right? Because that can happen as well, right? Does he need a pacemaker potentially? Has there been even an aortic rupture or a dissection, right? I talked about tamponade already. Does he have an acute kidney injury or acute kidney failure, right? And did they potentially malposition the valve, right? Are there any issues with the heart valve that they have replaced? So, but let's look at why does he potentially not come off the ventilator, and why are they saying there's a 35% chance of him needing a tracheostomy? Well, first off, he should be off all sedatives and all opiates by now. Right? That's number one. He should be off all sedatives, all opiates by now. That's number one. Number two, is he waking up? If he's awake, can he follow simple commands like squeezing hands, wiggling toes, poking out his tongue, blink his eyes? Can he do all of that? If he can do all of that, what stops him from getting off the ventilator? Is he potentially brewing a pneumonia? Right? You also haven't shared how many days your dad has been on the ventilator for. Is it 1 day? Is it 2 days? Is it 2 weeks? It could be simply a timing issue. What ventilator settings is he on right now? Have they tried spontaneous breathing trials? If they've tried spontaneous breathing trials, what did that look like? Right? If they tried spontaneous breathing trials, what did that look like? Did he fail them? What settings was he on? What are his arterial blood gases look like? What do they look like? Right? PO2, oxygen levels in particular, but also carbon dioxide levels, PCO2, and also the pH would be some good numbers to begin with. What do chest x-rays look like? Is there some consolidation? How much oxygen is he on? How much PEEP is he on? Is he in a controlled ventilation mode? Or is he already breathing spontaneously? Or is it a mixture of him getting 10 breaths a minute from the ventilator and he's breathing on top of that? If that's the case, why can they not lower the mandatory rate that he's currently getting? Right? How is the neurological disease impacting on him not getting off the ventilator? Is this nothing they took into consideration prior to going to surgery to look at risk management? Because he might have been a high risk for a general anesthetic to begin with, and maybe he didn't have a GA because it was minimally invasive. Again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is, once again, exactly what you are dealing with here. Also, with him not getting, or with your dad not getting off the ventilator, what are they doing? How are they managing that? Are they proactively mobilizing him? Is he getting physical therapy? Right? Is he getting physical therapy? Are they doing breathing exercises for him? Right? Coughing exercises. Is his pain well controlled, if any? Does he have any pain? And if he does have any pain, how is that controlled? Right? Is it controlled at all? Those are questions you need to look at. Okay, let's move on to the next question. That's coming from Verena, who says, "Hi Patrick, I have a question. Why was my husband put in an induced coma? Because while having surgery, his blood pressure dropped very low." Well, that's a good question. But the question is, was he not in an induced coma to begin with whilst having surgery? Many surgeries, not all, but many surgeries require an induced coma or a general anesthetic to begin with. So was he not having that? Was it a minimally invasive surgery, like we just discussed, like with the transthoracic aortic valve replacement? Right? And did he then lose his blood pressure? And is that why he got intubated and in an induced coma? That's probably the question here that I would want to know. Were they planning not to put him in an induced coma to begin with? And then, if he lost his blood pressure during surgery, then he probably lost consciousness. If he lost consciousness, that's when they probably needed to induce him in a coma and intubate him, unfortunately. That's what it looks like from the outset here. That's what it looks like from the outset here. You know. Okay, so let's move on to the next question. Oh, that's a good one. Question from Renee. My family has been asked to decide between weaning, extubation, or tracheostomy. Now, one thing that I see over and over again is that families in intensive care simply mix up terminology. And that's a case of mixing up terminology. So let's break this down. Deciding between weaning, extubation, or tracheostomy. Let's start with the term extubation. Extubation means the removal of the breathing tube in the mouth or in the nose. That's it. So if someone is on a ventilator with a breathing tube, most of the time the breathing tube is in the mouth. In some cases, the breathing tube is in the nose. Someone is ready for extubation. That is what's happening there. Simple. Hopefully the patient can then breathe independently. Hopefully the patient has been worked up for extubation, so they're ready to be extubated and that they can breathe independently with no more need to get back on the ventilator. That is what extubation is. There's one scenario with extubation that's sort of slightly outside of the norm, which is a one-way extubation. Let's quickly talk about one-way extubation. Some patients in ICU might have a one-way extubation for palliative care and end of life, but that can only happen if there's consensus from all parties. So what I mean by that, ICU can't just say, oh, we're doing a one-way extubation tomorrow because we feel like that's the best way to move forward, and then your loved one dies. That could be perceived as murder, could be perceived as euthanasia, and you got to keep that in mind as well, because we have many families all around the world contact us saying, oh, tomorrow at 3 o'clock, the ICU wants to extubate my loved one without our consent, and it's likely that they're dying, or that is murder in my eyes, right? Nothing short of that. So now that we've got extubation out of the way, let's look at the term weaning. So weaning off the ventilator is, should lead to extubation, should lead to that. That is when a patient is having ventilation with a breathing tube through the mouth or the nose. Then ventilation weaning should lead to extubation. There's a process, when someone is first ventilated, they're usually on a controlled ventilation mode, meaning, they have an SIMV mode or an ACV mode or a pressure control mode with a rate delivered by the ventilator, 10, 20 breaths per minute, whatever the case may be, with a PEEP, with some oxygen, right? And then you're gradually weaning the rate down. Let's just say there's a rate of 15, then you reducing the rate down to 15 breaths per minute to see whether the patient can breathe up, breathe on top of that spontaneously. If that's the case, you wean the rate further until eventually you're putting a patient in a spontaneous breathing trial, such as pressure support or CPAP ventilation. All of that goes well. Patient is obeying commands. Patient, has good and stable arterial blood gases, is cooperative. Take the breathing tube out. That would be an ideal scenario. That is for a patient with a breathing tube in the mouth or in the nose. The distinguishing factor here is weaning for someone with a tracheostomy, right? You can also wean a patient off the ventilator while they're ventilated via the tracheostomy. It doesn't really make a difference just from a weaning aspect, but it's better if you can avoid a tracheostomy. It is much better if you can just wean patients off the breathing tube so that they don't need a tracheostomy. Which leads me then to the last term of the email from Renee. Let me read out the email again. Deciding between weaning, extubation, or tracheostomy. So let's clarify the term tracheostomy. Tracheostomy, I will actually show you one. So that is a tracheostomy, right? So that's a tracheostomy. It sits in someone's neck. It's a replacement for the breathing tube that sits in the mouth. Okay, it sits in the neck, in the windpipe, and it's a replacement for breathing tube in the mouth. So with that said, the goal should always be to avoid a tracheostomy. That should always be the goal, right? When should a tracheostomy be done? It should be done if a patient has shown, beyond the shadow of a doubt, that they can't be weaned off the ventilator and the breathing tube within a day, 10 to 14 time window, right? And if they can't be weaned off the ventilator beyond the shadow of a doubt, then a tracheostomy might be the appropriate next step. Why is that? Well, a tracheostomy is so much easier to tolerate than a breathing tube, right? If someone needs a breathing tube either through the nose or through the mouth, often it goes hand in hand with an induced coma. Whether that's best practice or not, that's an entirely different conversation. I'm not going into that conversation today. I would encourage you to look at Carly Dayton's podcast. Carly Dayton is a critical care nurse practitioner in the US, and she's got some very good insights about whether an induced coma is necessary for patients that are intubated with a breathing tube, right? But keep in mind, the goal is always to avoid a tracheostomy. And I have also made a video and a blog post around how to wean a critically ill patient off the ventilator and the breathing tube. Because if those steps are followed, then a tracheostomy is not necessary, right? Like I said, tracheostomies have their time and their place, but it should be avoided whenever you can. So now that you know, the terminology, if your family member does need a tracheostomy, once again, same applies. Wean them off the ventilator as quickly as possible. Once they're weaned off the ventilator, wean them off the trach. But the question that you should be asking here, now that you know the terminology, the question that you should be asking here is, how can your dad avoid a tracheostomy? That's really the question that anyone should be asking here, right? Anyone on this call should be asking that question, or anyone watching this, is always how to avoid a tracheostomy, how to wean your loved one off the ventilator and the breathing tube. If your loved one, God forbid, needs a tracheostomy, again, the next question is, how can you wean them off the tracheostomy, right? So I hope that clarifies the terminology, and I can't stress enough, the best question to ask here is how to avoid a tracheostomy. That is the best question to ask. Okay. If you have any questions, type them into the chat pad or talk to me directly here on StreamYard. Click on the link and talk to me directly. So, next email is from Ashley. Ashley says, "Hi Patrick, my dad just went into cardiac arrest. He was out for 10 minutes and he was saved, brought to the hospital, had another episode of a cardiac arrest. He was put into an induced coma and has been in intensive care. He is not brain dead, but does show signs of a stroke or previous strokes. They took him on and off, and he had seizures, but seemed like he wanted to wake up, but couldn't." So when you say they took him on and off, you probably mean they took him on and off sedatives and opiates. That's what you are referring to here. He's 59, and it was found that he was a donor, and pretty much the same as one of your videos, although because he was an organ donor, they pushed end of life straight away. Take him off everything. Well, we tried, and he didn't pass away in the 2 hours, so he was brought back to his room here for another 24 hours until he was let go. I just feel like his heart was so strong, and his kidneys and liver were in great shape. I just don't understand why we gave him medicine and let him go like there was no other choice." Well, actually, I'm very disturbed by your email, and I congratulate you for sharing this traumatic experience, because it sounds to me like your dad has passed away. Now, let me lead with the following here. What I want to lead with here is that, once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. And the problem here is that you didn't know what you didn't know. And that was a deadly mistake, right? So let me lead with this. 90% of patients in intensive care survive, approximately. That's 9 patients out of 10 surviving. So why would your dad be the 1 out of 10 not surviving? Have you asked that question? You're asking the question now. Unfortunately, it's too late. So, what should you have done instead? When it is mind-boggling to me that patients and families, or families in particular, come to us when it's too late. It is mind-boggling. Now you're doing research when it's too late. And those are deadly mistakes, quite literally. So, it sounds to me like they might have euthanized him. You're referring to medicine that potentially killed him, right? So, did they give him morphine midazolam whilst they were taking him off the ventilator? Did a one-way extubation? I was just explaining in the previous question what a one-way extubation is. Is that what they were doing? Well, if it is what they were doing, I argue that was euthanasia. Right? Is there another way? Of course, there's always another way. You as the family, unfortunately, you didn't advocate properly. You didn't know what you didn't know. It boggles my mind that families are doing their research when it's too late, and yet when they have a family member in intensive care, they're just signing off on everything that the intensive care team is telling them. It boggles my mind. We have saved so many lives for our clients in intensive care. where we had situations like that we managed to turn around by giving you a second opinion, by looking at medical records, by talking to doctors and nurses directly, call them out on what they were supposed or what they were about to do, which is literally killing a patient. Have you ever asked yourself the question, what's the urgency to kill a patient? Have you ever asked that question? Have you asked that question, or did you ask that question when your dad was in ICU? I don't think you did. And that's very sad. That is extremely sad. Have you looked into whether that was a real or a perceived end-of-life situation? What's the difference? I'm glad you asked. A real end-of-life situation in intensive care is no life-saving medication, no treatment, no surgery, no equipment, no nothing will save your loved one's life. They're going to die. That's a real end-of-life situation. Well, a perceived end-of-life situation is a big difference. It's a perception. No more than that. What's your perception? Well, you signed off on everything that the ICU team told you. You were running towards the fire and you couldn't see it. For anyone watching this that is in a similar situation, let this be a warning. That if you don't do your research, if you don't take action when you have a loved one in intensive care, they might die. Even though the odds are in their favor, because you didn't do your research, you didn't get any help. It is unbelievable how many families are guilty of it. Let's call it for what it is. You know. So yeah, would there have been another solution? Absolutely. Continue treatment. That would have been the solution. Very simple. Continue treatment. Continue to keep him alive until he either is improving or until he can't improve. And that might be the situation then when you can entertain or start thinking about discussions around end of life, but not until you're ready. Maybe your dad would have woken up, then he could have made his own decision. But chances are, if he would have woken up, he probably wouldn't have said, I want to die. Right? It absolutely boggles my mind how naive some families are. You know, it is sometimes very naive of patients and families to believe that ICUs do have their best interests at heart. Very sad to hear that. Very sad to hear that. Okay, let's move on to the next question. There's been so many. Where do I even start? Where do I even start? And in the meantime, if you have any questions, type them into the chat pad. Yes. Email from Stephanie. Hi, Patrick. I just got my brother's medical records on day 8. I told my parents to get him off the Versed. Versed is a sedative also known as midazolam. The doctors want to meet tomorrow at 3 o'clock our time to see what we're going to do any further, and they want to push us towards end of life. Well, with the example that I just had a minute ago, you know what to do. There's 2 things you need to do here. Well, number one, you've got access to the medical records, which is great. That means you can get a second opinion, right? You can let us have a look at the medical records and break things down for you in much detail. That's number one. Number 2, now you know the odds, which is 90% approximately of intensive care patients survive. So you know the odds are in your brother's favor, generally speaking. Number 2, absolutely try and get him off the versed. Now, you haven't shared why your brother is in ICU, right? You haven't shared that. So there might be a need for him to be on versed. I wouldn't know, right? And this is why I'm saying when you reach out to us, give as much information as possible. You know, you don't know what you don't know. And the devil is in the detail. When someone is in intensive care, critically ill, there are dozens and dozens and dozens of things happening simultaneously. And unless you understand what's happening there, you're really flying blind. You are really flying blind. You know, and if you're flying blind, that's when ICUs can do whatever they want. And in the situation that we had a minute ago, you know, someone died. You know, it is very sad. It is very sad. But you know what to do. And here's another tip: do not go into the meeting if you know what's coming. Do not go because you know what's coming. You know what's coming. Why would you go into a meeting setting yourself up for failure? Why would you do that? Right? Why would you do that? Just don't go into the meeting. Just because they ask you for a meeting where they want to push their agenda, just don't go. So here's how to approach this in the most logical and effective manner. If they ask you for a meeting where they want to push their agenda towards end of life, just ask them to write down, to get an agenda in writing and see what they say. And then you decide whether you want to go, whether those agenda items align with your goals. Because I can assure you their agenda items align with their goals. I can assure you of that. You've got to have your eyes wide open, guys. Got to have your eyes wide open. You can't be flying blind when you have a loved one critically ill in intensive care. You cannot be flying blind. That's how serious it is, because you've heard it in the email before. Someone died because they didn't know what to do. Right? You know, that's how serious it is. And I can't believe how many families in intensive care just go into family meetings with intensive care teams completely unprepared. Right? I don't understand that. You know, those meetings are about life or death. Often. And you just go there because they ask you to, without an agenda in writing. Any business meeting has an agenda in writing, generally speaking. And there's no meeting agenda for a critically ill patient in ICU, where the meeting is about life or death. You just walk there because they ask you to, and you're not prepared. Give me a break. But that's what I'm seeing. So be prepared. Get help. And because if you're not getting help, it could be life or death. Well, it often is life or death. Okay, so let's move on to the next question. But if you have any questions, type them into the chat pad or connect with me live on the StreamYard link here. Click on the link and I can talk to you directly. Okay, next email is from Linda. Linda says, "Hi Patrick, my sister has a hypoxic brain injury due to a coding incident in the hospital. The hospital is suggesting to send her to LTAC, but her insurance is saying she doesn't have enough long-term care days. She's in the ICU and they already put in a tracheostomy and a PEG tube. She requires a high level of care and I don't know what our options are. I'm considering joining your membership." Yeah, that's, that is the best option, to join our membership and get some consulting and advocacy. For now, with what you are sharing with me here, Linda, doesn't quite make sense that they're saying your sister doesn't have enough insurance days for LTAC as opposed to an ICU stay, because ICU tends to be much more expensive than an LTAC stay. So consider that. But then, as you might know, I can see obviously that you're in the US. If you're talking about LTAC, no other country has an LTAC. Keep in mind that if she is going into an LTAC, we're very opposed to that, because things will only go from bad to worse. Now, whilst the trust might have been broken between you and the hospital because it sounds like she sustained a hypoxic brain injury from a coding incident in the hospital, whilst you're not making any accusations here, or you're saying, it was the hospital's fault, whatever the case may be. You have to consider that. Also, why is she needing a tracheostomy and a PEG tube? Part of the topics we covered earlier is, how to avoid a tracheostomy. Did you inform yourself how to avoid a tracheostomy, or did you just sign it off blindly? Right? Did you just sign it off blindly because they asked you to? Right? So, here's the thing. In some of my other videos, I would have talked about why you shouldn't give consent to a PEG tube in particular. Tracheostomies have their time and their place. Maybe a tracheostomy was necessary, I don't know. If you are being asked to give consent to a tracheostomy and you've done your research and you think it's the best way forward, then, do not give consent to a PEG tube, full stop. Do not give consent to a PEG tube, full stop. If you do, if you're in the US, you're giving the hospital and the ICU all the leverage to send your loved one to an LTAC. Do not do that. Do not do that. A nasogastric tube will suffice, and it will suffice for months on end, if need be. For example, with intensive care at home, we are taking patients home on nasogastric tubes. It should make you wonder and worried that LTACs cannot look after nasogastric tubes. That should have you worried if they don't have that skill. That should have you worried big time. I also encourage you, Linda, to have a look at your local LTACs, wherever they are, if you have any local LTACs, because sometimes hospitals are trying to send patients and families hours away from their home to put patients in an LTAC that is not even the beta version of a nursing home. Have a look at the online reviews of LTACs. Have a look at them. And let me know what you think, if you want your family member to go there. You haven't shared your location, but I have seen over the many years doing this, sometimes patients in Florida and ICU are being asked to go to an LTAC to Georgia. I have seen patients in Missouri being asked to go to LTACs in Kansas. And the list goes on. That is madness. That is madness as far as I'm concerned. Going to an LTAC is madness in and of itself. Going into LTAC in another state or hours away from your family completely boggles my mind. Right? There's nothing I can add to that. What I will add to that is you need to be prepared. You know, today, in all of the questions that I've answered, you know what they all have in common? People not being prepared. People just following blindly without doing research, believing that intensive care teams have the best interest at heart for you and your family member. Unfortunately, that is not all. That it's not always the case. That is not always the case. Unfortunately. Yeah. So all the questions today have in common that families are not prepared. And whilst I understand that no one's sitting at home thinking, oh, you know, if my family member goes into ICU, I wonder what I need to do. I get that. I totally understand that because, you know, those situations surprise you, come by surprise. I totally understand that. And I understand you have a life to live. You've got to go to work and, you know, I understand all of that. But you also have to understand the gravity of the situations that you cannot underestimate. You have seen today in the questions that I've answered that if you do underestimate those situations, they are deadly. They can be deadly or have a significant negative impact on your loved one's situation. Don't do that. Don't do that. Be prepared. Let's move on to the next question and probably to the last question today. If you have any questions, please type them into the chat pad or connect with me live here on the StreamYard link. I have a couple of minutes left. Usually I go for about an hour. You know, I go for about an hour and then I wrap this up. Next question from Jismi, who says, hi Patrick, my dad is in ICU and they're telling me I have 3 days to say goodbye before this Thursday when they want to remove life support. It boggles my mind. It boggles my mind. Jismi, well, you know, they're telling you, that they're asking you to jump off a bridge. Will you jump off the bridge? You need to ask the right questions. What's the question to ask you? How do I avoid? The question to ask is, how do I avoid trying them to kill my dad? You need to ask the right questions. Only if you ask the right questions will you find the right answer. Only then. You know, if you're not asking the right questions to begin with, you will be fighting an uphill battle. Very simple. Ask the right questions and the right answers will come. You know, I can tell you with 100% confidence that in a situation like that, we have saved all of them, as long as people hire our service, all of them, and as long as you can follow instructions. We have 100% guarantee there for saving a life in someone's in a situation like that, assuming it's a perceived end-of-life situation, not a real one. But I'm wondering, why are they already putting a timeline on it? You know, if he was that sick, why is he not dying now? Right? And removing life support without consent, that is murder as far as I'm concerned. Right? You gotta ask the right questions. And also, people have rights. you have rights. Right? You have rights. Very simple. You have rights. Because if you approach it with, well, I don't have rights, they can just walk all over me. Guess what they do? They will walk all over you. That's what they will do. Make no mistake. Okay. So I am going to wrap this up in a couple of minutes. Last chance to type your questions into the chat pad. So I do these YouTube lives every week, 10:30 a.m. Sydney, Melbourne time on a Sunday, which is today, I believe it's 6:30 Eastern Standard Time. In the US on a Saturday, which is 3:30 Pacific time, because I believe today the US is going into daylight saving. That means next week it'll be 7:30 p.m. Eastern Standard Time on a Saturday night and 4:30 p.m. Pacific time, and it'll stay the same here, 10:30 a.m. on a Sunday morning, Sydney, Melbourne time. Now, if you need consulting and advocacy, if you have a loved one in intensive care, go to intensivecarehotline.com. Our advice is absolutely life-changing. Absolutely life-changing. We have saved so many lives, and I'm very proud of it. Right? Very proud of it. And you can verify that, of course, on our testimonial section at intensivecarehotline.com, so you can see I'm not making it up. There's a testimonial section, and there's also our intensivecarehotline.com podcast, where we have done client interviews. You know, it's all documented and verified, so that you can see I'm not making it up. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or if you go to intensivecaresupport.org directly. I also do one-on-one consulting over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. I also talk to doctors and nurses directly on your behalf or with you. I set you up with the right questions to ask. And I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time, so that you can get that second opinion in real time. And we also do medical record reviews after intensive care if you have questions, if you need answers, if you're suspecting medical negligence, or if you're simply needing closure. If you want intensive care at home, go to intensivecareathome.com. Go to our website. We're currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are NDIS, TAC approved, NIISQ, iCare, DVA. You know, the funding is usually there. Just reach out to us at intensivecareathome.com. Now, thank you so much for watching, everyone. Lastly, we're also providing NDS support coordination for intensive care at home and TAC case management. Thank you so much for watching, everyone. Like, comment, subscribe, share the video, and thank you for your support, and I look forward to talking to you again next week. Take care for now.